ಗುರುಭ್ಯೋ ನಮಃ. ಎಲ್ಲರಿಗೂ ಶುಭ ಸಂಜೆ. ವೇದಿಕೆ ಮೇಲೆ ಆಸೀನರಾಗಿರುವ ನಮ್ಮೆಲ್ಲರ ನಲ್ಮೆಯ ಗುರುಗಳಾದ ಡಾಕ್ಟರ್ ಶರ್ಮಾ ಸರ್ ಅವರೇ, ನಮ್ಮ AFI ದಕ್ಷಿಣ ಕನ್ನಡ ಜಿಲ್ಲೆಯ ಅಧ್ಯಕ್ಷರಾದ ಶ್ರೀಯುತ ಡಾಕ್ಟರ್ ಕೃಷ್ಣ ಗೋಖಲೆ ಅವರೇ, ಆಯುಷ್ ಹಬ್ಬದ ಪ್ರೆಸಿಡೆಂಟ್ ಆದ ಡಾಕ್ಟರ್ ಕೇಶವ್ ಸರ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಪ್ರದೀಪ್ ಸರ್ ಅವರೇ, ಹಾಗೂ ನಮ್ಮ ಆಹ್ವಾನಕ್ಕೆ ಓಗೊಟ್ಟು ಬಂದಿರುವ ಎಲ್ಲ ಹಿರಿಯ ವೈದ್ಯರೇ, ವೈದ್ಯ ಮಿತ್ರರೇ ಹಾಗೂ ಕಿರಿಯ ವೈದ್ಯರೇ, ಇವತ್ತು ಬೆಳ್ತಂಗಡಿ ತಾಲೂಕಿನ ಆಯುಷ್ ವೈದ್ಯರೆಲ್ಲ ತುಂಬಾ ಖುಷಿಯಾಗಿದ್ದಾರೆ. ಯಾಕಂದ್ರೆ ನಮ್ಮ ಹೆಮ್ಮೆಯ ಶರ್ಮಾ ಸರ್ ಇವತ್ತು ನಮ್ಮೊಂದಿಗಿದ್ದಾರೆ. ಇದು ನಮ್ಮ ತುಂಬಾ ದಿನದ ಕನಸಾಗಿತ್ತು, ಶರ್ಮಾ ಸರ್ ಅನ್ನು ಕರೆಸಿ ಒಂದು CME ಮಾಡಬೇಕು ಅಂತ. ಆಗ್ತದಾ ಇಲ್ವಾ ಅಂತ ಹೇಳುವ ಒಂದು ತಳಮಳ ಸಹ ಇತ್ತು. ಆದ್ರೆ ಸರಿಗೆ ಒಮ್ಮೆ ಅಲ್ಯೂಮಿನಿ ಮೀಟಿಂಗ್ ಹೋದಾಗ ಕೇಳಿದ್ದೆ, ಸರ್ ಹೀಗೆ ಬರ್ಬಹುದಾ, ಕರೆದ್ರೆ ಬರ್ಬಹುದಾ ಸರ್ ಬೆಳ್ತಂಗಡಿಗೆ ಅಂತ. ಆದಿತ್ಯವಾರ ಆದ್ರೆ ಬರ್ಬಹುದು ಅಂತ ಹೇಳಿದ್ರು. ಹಾಗೆ ಈ CME ನಮ್ಗೆ ಡ್ಯೂ ಇತ್ತು, ಆಯುಷ್ ಹಬ್ಬದ ಮುಂಚೆ ಆಗ್ಬೇಕಿತ್ತು. ಮೊನ್ನೆ ಒಂದು ಫೋನ್ ಮಾಡಿದ್ದೆ, ಸರ್ ಹೀಗೆ ಉಂಟು ಬರ್ಬೋದಾ ಅಂತ. ಅಲ್ಲೇ ಆಗ್ಬಹುದು ಅಂತ ಹೇಳಿ ಒಪ್ಕೊಂಡ್ರು. ಅವ್ರು ಅದಕ್ಕೆ ಹೇಳೋದು ತುಂಬಿದ ಕೊಳ ತುಡುಕುರಿಲ್ಲ ಅಂತ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
That's a good opportunity to see all my old friends' faces and get introduced to them. And I thank Madam Dongre and Kukule and all that. The whole series of this lecture, now this is a second episode of that second series. It started with an idea, like when Gokhale asked me to talk about technology in Ayurvedic practice. I said, instead of talking about technology, I think how we will use the modern clinical investigation and how it can be useful in Ayurvedic clinical practice. That is the idea. And the whole idea started with the idea of discussing about the use of investigations in the clinical practice, and thereto the judicious use of clinical investigations. See, clinical investigations, they are plenty, and many times these investigations are misused in the clinical practice. So from that point of view, how to make use of the judicious use of these investigations in Ayurvedic practice, that is the idea. And we started with the 2 episodes, already 2 episodes completed. This is the 3rd episode where the topic given to me is about Prameha. And when we discuss about Prameha, instead of going to all the theory, 20 varieties of the Prameha, we will focus only on diabetes mellitus. Other part, like which are the other Pramehas and so on, that part I think we will not bother about now at this stage. And of course, in the earlier series of lectures, we have discussed about maybe how to identify these 20 types of the Prameha in the present situation. So that part I think we will not go directly. So we directly delve into the topic of diabetes mellitus and how we deal with the clinical practice. There again, how I deal with the clinical diabetes mellitus in my clinical practice, that's one part which we have already discussed in the earlier series, and that video is available. And in the present day's topic, I will be dealing with how the investigations help and how to arrive at certain confusing issues. In the clinical practice, we do meet with certain confusing issues in the diagnosis as well as management of the diabetes mellitus. How I deal with my personal experience, that's what I would be dealing with. A bit of theory, of course. Now, next slide. Now, of course, diabetes is a very prevalent disease condition, and as per the data statistics, as the incidence of diabetes is increasing and increasing rapidly. And as per the prediction, by 2045 in India, the total population of diabetics will be 134 crores, which is almost the same number of total population now. So if there would be no addition of numbers to the population, by 2045 all will be diabetic. That's the simplest explanation. So it is going to be very high asset, and every year the number is increasing. And as per the official data of 2023 ICMR data, over 101 million people are already diabetic. Another major concern group is 136 million people are pre-diabetic. Now these pre-diabetics are the ones which really produce more confusion in the clinical practice, how to deal with them and how to convince them. Many times the patients would be having certain confusion, lots of queries, and of course with the Google era, you will have questions which would be very difficult to answer. So from that point of view, we need to be aware of the current trends, that's all. And among these diabetics in India, now I am specific about India, 90 to 95% are type 2 diabetes. Type 2 diabetes patients are mainly due to the diet and exercise. That type 1 diabetes, of course, there will be some other issue. So more focus of whatever I discussed would be on the type 2 diabetes as such. Type 2 diabetes would be the major focus as such. So next. Now investigations, how to diagnose the Prameha, what Taraka or Sushruta were dependent upon would be the natural examination, and that's the ants being attracted by the urine as well as the sweat and the body of the patient. So because of the test, though it looks funny, we have to appreciate that part, like they had attempted to make an objective analysis, find an evidence. Now we say evidence-based medicine. We say evidence-based medicine is a modern concept. It's not only modern concept. In those days, 5,000 years ago, there was a good attempt to find the evidence and establish the evidence based upon the natural resources. Of course, we need to appreciate, but I don't say that that test is complete and that test is dependable now. It may be having only historical importance, but from the present day's point of view, in the contemporary history of Western medicine, compared to what Sushruta had said 5,000 years ago, Charaka Sushruta 5,000 years ago, in Western medicine, an idea of identifying the sweetness in the urine, it started only 1776. So from the Western medicine point of view, that relationship between the sweetness or sugar and the disease, diabetes, whatever it is, it's just around 500 years. We have a treasure of information for 5,000 years, but now we are dependent upon that information which has been developed in 500 years. Why and how, I think that's not the part to be discussed. Anyway, from Ayurvedic point of view, we have lots of issues to be regretted from that point of view. Anyway, that's not the point. Now, the historical timeline of identifying these different technology or evolution of the technologies in the Western medicine, of course, it's all just gradually. I think we will not much focus on that. But the idea of identifying the blood sugar level in the blood instead of depending upon the body secretions like urine, it was started only 1930. So that's around 100 plus years. So history of identifying the blood sugar level was just around 100 plus years, and then of course you have that different modalities. We will try to make out that. Next slide. And the maximum, that latest evolution of that identifying that HbA1c, glycated hemoglobin, it was in 2009. So there is a very progressive, gradual, step-by-step evolution in the investigational techniques related to diabetes. And current trend, of course, still there is lot of expansion, lot of variations. Now, how many of these variations are really useful? How many of them are confusing? That's all the major focus of what we are going to discuss. Next. Now, basic issue about the maintenance of the blood sugar level. Initial days, the whole diabetes and sugar level was supposed to be dependent only on pancreas and insulin. So, it's now known that it's not only the insulin and pancreas. Insulin is what we see from the exterior, effect of insulin is what we see from the surface, but the inherent basic issue is the factors which control the sugar are not simply the insulin, it's about it's now identified areas are, one is the brain irate axis. The secretion of insulin is dependent upon the function of the brain, your stress, the other factors related to the activity of the neurological system. It's not only that there is a direct hormonal control, the other activities of the brain tissue also would be producing or having some impact on the secretion of insulin. More important is the gut irate axis, gastrointestinal tract and the insulin secretion. It's related to the food and related to the activities, physical activities. The other would be the adipose tissue, another adipose tissue axis, the fat tissue in the body, which will have a direct influence on the insulin activity. More the fat tissue in the body, the insulin resistance chances are more. It requires more insulin to maintain the oxygenation as well as the glycation, that providing glucose to the adipose tissue. And these are the main causes for the type 2 diabetes. Type 1, of course, is totally different, where there would be an organic damage to the pancreas or maybe a real secretion of the insulin being reduced. Now, important is in these type 2 diabetes patients, insulin secretion is either normal or above normal. It's not deficient. 99% of these patients would have a insulin secretion which is above normal or at the normal level, but they would have diabetes. So idea of insulin and diabetes mellitus, that is now being questioned specifically in type 2 diabetes. This is important. Type 1, of course, it's totally insulin dependent, no argument on that part. But type 2 diabetes, that the utility of insulin is a questionable issue, but still the current trend of clinical management would be to prefer for insulin. That's the other part of. Now, from the Ayurvedic point of view, the same gut islet axis is defined as Asya. The brain axis is considered as the Swapna Sukham. So Asya Sukham, Swapna Sukham. Then of course you have the food like Dadhini, Gramya, Anuprasaha, Payamsi, Namannapanam, Guruvayanakere. These are the different diet factors which are supposed to be triggering factors for the Prameha. Right. Next. Now the most important part from the practical clinical point of view, the most important part in the development of diabetes mellitus, more than 50% of the diabetic patients whom we see would have a adipose tissue abnormality, and that abnormal adipose tissue which is present throughout the body produces that obesity. It requires more energy to maintain that body fat, as well as the physical activities require more energy, and as a result of that, because of this increased demand of energy, insulin initially is secreted more. That insulin is utilized for the metabolism of the adipose tissue only, and hence the other tissues would have a deficiency of insulin. So it's what we call as insulin resistance. The majority of the patients whom we see are of insulin resistance, and hence their glucose level would be abnormal. To identify this exactly, differentiate, is quite difficult, but most of the times we have to depend upon indirect evidences to conclude, like whether it is the adipose tissue which is responsible, or insulin resistance which is responsible, or whether it is a insulin reduced activity which is responsible for the diabetes. These are the issues. Quite important is in the patients who have insulin resistance, virtually most of the current anti-diabetic treatment are of no use. They can be managed better with the diet and exercise. But in those patients who have a real insulin deficiency, secretion abnormality, in that condition, of course, these the anti-diabetic drugs are definitely useful. Now, from that point of view, to identify a patient as diabetic, that role of fat, again, it was established by Charagat as such. The dhatus involved, the number one dhatu is Medhashta, and then Mamsancha, then all that would be the same, which results in exactly the same pathology, where results in including the involvement of the other dhatus. Almost every dhatu in the body would be involved. So insulin is a multisystemic pathology. I think that shloka is already read and forgot. Now, one more important confusing issue in the clinical practice would be, what is the normal glucose level? Most of the laboratories, when they give the result, the laboratories would have some normal value, and this normal value also would vary according to the type of test they do. Some of the chemical reagents, some companies' chemical reagents, the normal value is different, and in some others the normal value is different. There is always some confusion. But the WHO accepted a standard normal value of the blood sugar level in an infant at the cord, umbilical cord. If you collect the blood at the time of the birth, it's a 2.5 to 5.3 millimoles. In case of premature infant, it's a 20 to 60 milligram per ml. In neonate, that's up to 3 months of age, it will be 30 to 60 milligram per 100%. In a child at 2 years, up to 2 years, it's a 60 to 100 ml is considered as normal. In adult, 74 to 106. This is the universal accepted standard benchmark accepted by WHO. What the laboratories they give you, they do not make out this difference, age and other factors. They give you some set of normal value, which again produces lots of confusion in the clinical practice. Now, the critical values. Now, whenever the patient has a sugar level which requires an emergency, it presents emergency as such, where you have to directly tackle the sugar level immediately, as early as possible. That's what we call as a critical level. When it is in adult, when it is less than 50 milligram per 100 ml, or when it is more than 400 milligram per 100 ml, both are these considered as a clinical emergencies, where you need to tackle that as early as possible. In other conditions, gradually you can take some steps, gradually, step by step, and then deal with the diabetes as such, unless there is some other clinical issue. So if it is a simple diabetic issue, it need not bother. Whereas adult female, it is a 40 to 400. In infant, less than 40. In infants, the chances of having a high blood sugar level resulting in critical issues is very lesser, and in newborn 30 to 300 milligram. That's what the universal standard says. Of course, from the clinical point of view, our focus mainly would be on the adults. Which of the sugar level has to be considered as the most useful for the clinical practice? Identify a diabetes, fasting or postprandial. Fasting, of course, is given a lot of importance important, but most of the times what happens is that standard time for the fasting itself is often missed. Ideally, there are 8 hours of fast, 8 hours, nothing should be taken, and then the blood sugar level has to be assessed, which practically often is not possible with our Indian conditions and those where you have every opportunity to have the food. The moment you see a friend, there will be some offering of the food. Every case is an opportunity, and when you, death also you will have a feast, birth also you have a feast. That's our culture, and in such situations, naturally, that fasting time may not be standard fixed. Better would be, better dependable would be postprandial, where at least 2 hours can be maintained for once you take the food. After 2 hours, if you collect the sample as such, so standard is 2 hour postprandial. But many times people say that 2.5 hours, okay, that half an hour is a confusing issue. The normal values in that condition is less than 140 in adults of 0 to 50 years, 50 to 60 years, 150. This is another important issue. You get a good number of patients in this age group where they may have a postprandial sugar in between that above 140 and in between 150, and they would be worried. Even if the patient is not worried, patient's son or daughter would be worried, and they will be pushing him to the doctors, and naturally there will be a bit of over treatment. That's also the issue. But ideal standard limit for postprandial blood sugar in the age of 0 to 50 is 150, whereas above 60 is 160. So blood sugar requirement, postprandial requirement according to the age would be increasing. Now this part also is not mentioned in the laboratory reports as such. They would not bother about that age distribution. Now to avoid this error, earlier when we were studying like 80s, the popular method of confirming the diagnosis will be by glucose tolerance test, where you will give a measured glucose and then take the blood sample every half an hour for 5 samples would be taken. But this itself is a tedious process. But definitely, as far as the definite identification of the type of the diabetes, glucose tolerance test is the golden test practice. This practice has become obsolete now. Practically no one does that now, because taking 5 samples itself is a tedious job. To have that prick every 2 hours, again patient may not be ready to give money for that, give money and then pick again 5 times. So any reasons, this technique has now become almost obsolete. Very rarely in very sophisticated hospitals this GTT is done, particularly in the patients who are in ICU, this could be done. Otherwise rarely it is done. With that, the typical pattern of the distribution is made out. Normally, the fasting level would be less than 100 and it would reach the peak of less than 140 by 2.5 hours. And very important is by 3 hours as such, or 2.5 hours, at the end of 2.5 hours, it should come back to the original fasting level. Then only we say that it is normal. Any other alteration could be produced due to other reasons. Among those factors which can produce a abnormal blood sugar level, high blood sugar level, one is important is elementary glycosuria. Elementary glycosuria is once you have a fast for long time, you have avoided food and then you take the food, the sugar level will be suddenly increased. After fasting, after Ekadashi, if you have really followed the Ekadashi, next day if the sugar level is recorded, after 2 hours the sugar level will reach the peak. But this is not diabetes. This is not diabetes. It's about the food intake balance which is not proper. Similarly, there would be certain food substances which have a different glycemic index. Hyper or glycemic index of a specific food also is now known. Simple sugar is well known to have a very glycemic level, that the moment you eat it, the blood sugar level rises within short time. Whereas the food like wheat and so on, they would have a longer time to raise the blood sugar level. So it also depends upon the type of the food, that there could be a sudden peak in the blood sugar level, which may not be always definite of the diabetes. To confirm that the patient is having diabetes in a GTT, glucose tolerance test asset, the fasting level and 2.5 hours level, they should be within the normal range. Then you consider it as a diabetes. If anything is other than that, the other possibilities are many times the blood sugar level initially could be normal, even the peak could be within the normal limit, but the patient may not have that normal level reached after 2.5 hours. It may prolong, it may take 3 hours, 4 hours. That patient would be more concerned. There has to be concerned. It's a pre-diabetic, though the blood sugar level throughout the test is normal, within the normal range, I see, within that peak range, that patient has a high risk of developing the complications of the diabetes. He is prone for diabetes. Most of those persons who tend to have a genetic tendency for diabetes, those who have familial history of diabetes, they tend to have this kind of abnormality. They may maintain their sugar level within normal limits by strict diet control, but the time taken for the sugar level to come back to the normal level would be longer, 3 hours, 4 hours and so on, and that itself also could be a cause for the clinical incidence of diabetic complication, and you may miss that way. So there is always a possibility of either overdiagnosis or there is a possibility of underdiagnosis unless we have a very clear picture of the sugar level. But as I told you that GTT now has become obsolete, we have to depend upon the other means of making the diagnosis. That's the next. Now the other variations now from our International Diabetologist Association, these variations are subclassified. Now I have told about only the simple classification of elementary glycosuria and pre-diabetic and diabetic. But the present days, these variations which have to be considered are either fasting plasma glucose more than 125 milligram but otherwise being normal, or random glucose greater than 200 ml, that also is considered as an abnormal variation. They are not named as diabetic. And postprandial glucose at 2 hours is greater than 200 milligram per ml. These three categories of the patients, they are not diabetic patients. All that they require is a regulation of the diet, and if you maintain that regulation, diet and exercise is correctly advised, it could be the quantity of the food he has to take, type of the food he has to take, and the exercise, that would be enough to manage the patients, and all the diabetic complications can be avoided. So very often you see the patients who are overtreated, where the patient could be of within these variations of the diabetes sugar level, but they are treated with the diabetes, are treated as diabetic, and lots of medicines are being used. It's not necessary. 100 to 125 fasting glucose being more, or employed glucose tolerance testing where the postprandial sugar is more than 140 to 199, that's nearly 200. These patients are classified as a suspicious case, where you will have to depend upon the other clinical signs of diabetes, and if the patient has other signs of diabetes, or there is a tendency for diabetes otherwise in terms of the families, in such conditions the patient may have to be treated as a diabetic. Otherwise again that can be watched. We say that it is a condition under watch. You have to continuously observe, monitor, and see if there is a need for diabetes, and a diabetic treatment is required. Otherwise not. So that's one aspect. Next, now from the clinical point of view, another issue which often is seen is many patients come with the report of fasting and postprandial blood sugar level, and a good number of patients may have a fasting blood sugar level more than the postprandial level. Postprandial level could be less than the fasting level. This again produces confusion, and younger generation Google patients now, Google expert patients, they will have hundreds of such questions. The reason for this, now this is common, and the reason for this, the most important is reactive hypoglycemia. Patients who are treated with the anti-diabetic drug, and when the anti-diabetic drug dose is more than normal, more than what is required, you usually use lots of combination drugs. Like when the combination drugs are used, that reduces the blood sugar level immediately, and often its sugar level is reduced below that optimum level. And at night, when the drug concentration is lesser in the body tries to compensate with that, and that is produces a increased sugar level, and this increased sugar level results in a higher fasting sugar. Now in such patients, the night dose has to be modified. I usually say that the night dose to be reduced to half. If the patient is using a multiple drug combination, I say you have to depend upon single drug, switch to single drug. With that reactive hyperglycemia can be managed, that fasting blood sugar level being more than the postprandial level, that can be managed. The other important issue is dietary habits. Like if you have to see that a patient, you say that at night he is supposed to be fasting, but many patients may take some food in between. At times people keep some cup of milk or some other food near the bed, and in between they take. So that unreliable fast, that itself could be the cause. Of course that's something which is beyond that what we call as a medical perception, but it's a practical issue which we have to consider, and many times the patient has to be educated. The other factors which can produce is the physical activity, particularly if the patient does not do any exercise after food, habit of sleeping immediately after the food without doing exercise, having lesser gap between the bedtime and the food time, that itself can result in a higher fasting sugar level, because there is no activity to consume that. So in another advice to such patients would be keep a gap between the food intake and the bedtime, and do some relaxing exercise, simple walking or some relaxing exercise. That also can manage that issue, which is not a major issue but issue of concern from the clinical point of view. You will face such questions, and that can be modified with that. The other of course is the sleep quality. Patients who do not have a proper sleep, they also, that all that sleep disturbances, they various cause, that also can affect the fasting fasting glucose level. Of course, that's a relatively minor issue, but not a more important issue. Then patients who have the gastric abnormality, particularly gastroparesis, patients who have undergone gastric surgeries, gastrostomy types of surgeries, the gastric emptying period is altered. Patients who consume lot of anticholinergic drugs or the proton pump inhibitors, these days that's one of the epidemic. Almost every patient would have, every person would have the proton pump inhibitor in his pocket, and it is available in every BD shop also. And taking that tablet regularly has become a good habit now, rather a very common habit, and many times you cannot just ask the patient to stop that also, because the patients are somewhat addicted to that, and that itself is a cause for lots of complications. That habit of proton pump inhibitor consumption or any of those gastric irritation reducing good number of them are not only proton pump inhibitors, all of them, they would have their own adverse effects, and that adverse effect is one of the major concern, and one of the adverse effect of such consumption of the food is altering the blood sugar level. Particularly the fasting sugar level would be tending to raise up much, and that itself can produce aberration. We need to consider these issues, and with that this aberration can be managed. I am not yet going to the issue of diabetes mellitus. It's about the peripheral conditions which may mimic diabetes mellitus and produce a clinical issue, clinically get this problem. And of course the rapid changes in the sugar level, that itself is mentioned, though not exactly in the same word, from Samhitas. It's not something new, where the Samhita says in a patient who have the tendency for the Prameha would have kshanat purnaha kshanat kshinaha. The variations in the blood content, the dhatu status tends to change rapidly, and it's also true that the blood sugar level would be continuously changing. It is dynamic. Whatever we take as a sample blood sugar level now, it would be just 1 minute. At that minute the sugar level is seen, but the biochemical changes which occur in the body are a continuous process. And I always compare this to what we see in the old traditional film, where slides, the films would be run at a faster speed. When the film is or pictures are run at a faster speed of more than 60 per second, you will feel a continuous activity. Amitabh Bachchan hitting somebody, if at all you see that films one by one, like in olden days in some festivals you had that some dabba box where you will be able to see some shots like. Now these short, if at all you see, it will be like Amitabh Bachchan initially raises one hand, then 1 centimeter down, 1 centimeter down. So that's a step by step. Whatever we see as the biochemical investigation, these are analyzing these steps. It's not the continuous process, and the continuous process cannot be directly assessed as, and hence there is another alternative method of identifying this. That's next slide. There comes the HbA1c or glycated hemoglobin. Physiology of glycated hemoglobin is, again I will not go into very deep detail of that glycated hemoglobin. The simplest is the hemoglobin metabolism is different from the metabolism of other tissue. In other tissues, glucose is metabolized into carbon dioxide and water, and it's an oxidation energy. It results in conversion of ADP to ATP, and the energy is stored. But in hemoglobin, the type of energy required is not of oxidizing energy, it's a reducing energy, where the oxygen combination with the hemoglobin should be only temporary. Oxygen should be taken in the lungs. At the tissues, it should be released. It's not oxidized, and hence the energy required for the hemoglobin is a reducing energy, where the glucose passes through pentose phosphate pathway, where the 6 molecule carbon of glucose is broken down into one single carbon molecule of carbon dioxide, and the other would be remaining as a pentose acid, and this energy is stored in the form of a reduced energy. Nicotine adenosine hydrogen combination, NADH2, is the storage, and this unique pattern is required for the maintenance of the metabolism of hemoglobin. Now, if the glucose level is raised, that raised glucose level would affect the configuration of the hemoglobin, and the hemoglobin becomes something like comparable is like the cheese on milk. When you boil milk and then keep it stored, you will have a layer of cream over the milk. So that kind of a cream-like substance will be deposited over the hemoglobin, and the oxidation energy will be affected. That results in the glycation of, so it is a simple like something like the example I have given is when you heat any proteinous substance with sugar, that results in some thick substance, the caramel. Now I think they use the word when sugar is heated and then it becomes blackish, that's called as caramel. So a similar phenomenon, the best example, simplest example of what I mean by glycation is the hemoglobin becomes a caramel. Right, next. Now, and hence hemoglobin HbA1c is considered to be a benchmark, because that glycated hemoglobin hemoglobin can remain stable for 120 days average. So it's considered as a 3 months average. Though it can remain for 4 months, we consider practically this as a 3 months average, and this gives a better idea about that continuous status of the glucose level. If the glucose level is raised for even a shorter duration, that can produce the impairment of the hemoglobin, and hence that hemoglobin, glycated hemoglobin level is raised. We say that his sugar level is not controlled properly. He needs a treatment for that maintenance of the glucose. I don't use the word treatment for diabetes. I say a treatment for maintenance of the sugar level. Hyperglycemia has to be treated. So not that every patient who has a raised HbA1c is diabetic. Many of those patients who have impaired glucose level also may have a marginal raise in the HbA1c level. So there we have to consider these issues and decide like whether the patient really requires a treatment for diabetes or a management of the sugar level. Management of the sugar level doesn't need medicines. It's about the lifestyle and diet. That's all the issue. Now a HbA1c level also could be varied due to other factors other than that of the glucose metabolism. A low hemoglobin level, HbA1c level could be produced due to patients who have a hemolysis. If there is a destruction of the RBC produced due to other reasons, and the patients who have a splenomegaly, spleen enlargement, and hence the issues, or even in case of malaria when there would be hemolysis, the HbA1c level tends to be reduced. Many drugs also are known to induce this. Among them, the most important is the anti-lipidematic drug, dapsone. Patients who are on anti-lipidematic drug for quite a long time, because it's as such it requires a very prolonged treatment, and in these patients there is always a tendency to have this raised HbA1c level, or even the glucose level also would be altered. Whether the patient requires a treatment for diabetes or not is the other issue. Again, that becomes one of the issues, and we get such number of patients quite frequently. Others, of course, retroviral drugs also can produce the same changes, and the post-splenectomy patients who have undergone splenectomy also, the HbA1c level also are increased abnormally because RBCs are not properly metabolized or is not destroyed properly. And patients who have received blood transfusion, recent blood transfusion, there too the hemolysis is a consequence later on. There too HbA1c level could be altered. But from the practical clinical point of view, not much of a issue. Many times HbA1c level could be affected by alcohol intake. Persons who consume alcohol, the HbA1c level may not be totally reliable. You need to depend upon the other parameters to conclude whether the patient is really diabetic or not. Of course, most of the patients of alcoholic category, they require diabetic treatment. That's also true. And patients who have jaundice, hyperbilirubinemia, they too tend to have a HbA1c level being raised abnormally, and particularly if the patient is addicted to opiate drugs, opium related drugs, and patients who have a high cholesterol level, triglyceride level, high triglyceride level, they may have a low HbA1c level. So many patients of that category who are really diabetic, their HbA1c level may be misleading. That also is possible. And the patients who have abnormal hemoglobin, like hemoglobin disorder, different sorts of hemoglobin disorders, that also, but they are not more common issues. More common issues from the clinical point of view are obese patients and alcoholic patients who have altered the HbA1c level, but it may produce some confusion. Next. Then another technique which has come up now recently is a continuous glucose monitor. These instruments are now available. Even in India, this instrument is available. Very simple tool. You just stick a sticker over the surface of the body, and with your mobile, you can record the sugar level any moment. This produces a craze. Once you start with that, you may have a craze throughout the day. You will be just monitoring the sugar level. But still, in a patient who is diabetic or who has a tendency for diabetes, it could be a useful tool to identify. Cost now is around 5,000 rupees. 5,000. We're dealing with that metabolic syndrome more as a complication of the diabetes than really the cause for the diabetes. So metabolic syndrome issue we will discuss at the end. Pre-diabetic is the other issue. Again, a good number of patients, now as I told in the beginning about the data, more than the diabetic, you have a large number of patients who are pre-diabetic, and these pre-diabetics, when they are treated with the more effective anti-diabetic drug, and one of the dangerous trend in the current practice now is once the sugar level is altered, they say that instead of going for oral hypoglycemics, you start with the insulin. Insulin has become a trend now, and these patients who are pre-diabetics, they do not require insulin at all, and even the oral hypoglycemics are not necessary, and this kind of over treatment makes them permanently diabetic. Once you start with that artificially manipulating the sugar level, then that patient would have a definite impaired sugar level, and hence in all these pre-diabetic patients, it's always justified to give a sufficient trial with the diet and exercise. Regulation of the diet and exercise itself would be enough in a more than 70% of these patients. Only 30% of the patients may require a anti-diabetic drug or anti-diabetic treatment, maybe oral or the other way. Most of the times they can be managed with the oral hypoglycemics only, and that would be one of the important tool by which a pre-diabetic can be converted more into a normal would be Virechana, which I have seen in large number of patients. And whatever the text says, Virechana as the choice of the treatment in Prameha is absolutely true in case of pre-diabetic condition. Once the diabetes is established and then the patient has a complication, Virechana may not show that kind of a dramatic results. But Virechana is definitely used, and it is very dependable in these patients who have a pre-diabetic condition. A Virechana followed by diet and exercise can reverse the diabetes. Now there is one very popular word now and has become a trend, is reversal of diabetes. Reversal of diabetes is possible in pre-diabetic condition. My question is whether there is a need for reversal or whether it's really prevention of. I would say prevention, because there is no question of reversal because they are not diabetic. That patient is not diabetic, has a tendency for diabetes, and in that patient to avoid the diabetes, is it justified to say reversal? Okay, all right, but this has been a commercial trend. I am not going to criticize that issue. Anyway, that's the other trend part as such. And as far as if you use that word still reversal, the best tool which I have found out is maybe Virechana, and it's what the text would say, the Samhitas would say. Right, the definition of that pre-diabetic is where HbA1c is between 5.7 to 6.4 and the fasting blood glucose is 100 to 125, postprandial is 140 to 200, less than 200. That's considered as the pre-diabetic. I think you may have some 10 to 15% margin beyond that, still that can be considered as a pre-diabetic in our conditions, in Indian conditions, where in total the food intake is more. So that's the. Now from academic theory point of view, practical issue of course is not a very critical issue. Of course it may have some significance, so bit higher level of academy. I think for practitioners much of these issues may not be very significant. The current method of classification of diabetes, earlier classification when we were studying, it was only just to type 1, type 2. Now there is a lot of sub-classification because the most investigation tools have come up, and that use of investigation tools has resulted in identifying these diabetes into sub-classification. So from the theory point of view, practically these have very little importance. The type 1 diabetes is classified into a acute onset type 1 diabetes where there is a real beta cell damage or number of beta cells are lesser. Then there is a latent autoimmune diabetes. Autoimmune pathology being responsible for the diabetes is one of the evolving knowledge, new knowledge coming up, and this also is identified as a slowly progressive adulthood type 1 diabetes. Now the difference between the other is in a typical type 1 diabetes it's always juvenile, where the diabetes is seen before the age of 16. That's usually where there is a definite deficiency of the beta cell, whereas insulin dependent diabetes occurring in the adult, gradually it is occurring, and you have all the tendencies or clinical presentations of the type 1, and the type 1 diabetes patients are usually weaker, they tend to lose weight, and their this appetite would be lesser than the optimum, whereas a type 2 diabetes would be obese, overweight, and their appetite would be more. So Krisha Pramehi and Sthula Pramehi, Krisha Pramehi mentioned in Charaka is the type 1 diabetes, and that occurring in adult is usually autoimmune. But that knowledge, like whether it is autoimmune or whether it can the other way, has very little scope for the management now as such. But in due course of time, we may have some new tools to come up in that area. But from our clinical point of view, in that kind of a type 1 diabetes of gradual onset, Virechana may help, but it's not as dependable as the condition. Diabetic complications in that condition can be reduced with Virechana, but I don't say that it can replace, Virechana can replace the insulin requirement. Insulin requirement may still be there. We may be able to reduce the insulin dosage in due course of time, but it may not be possible to stop the insulin. And this is possible in the adult onset type 1 diabetes, which could be often of this autoimmune worry. Whereas in juvenile diabetes, Virechana doesn't help much. I have seen in many patients, Virechana doesn't help, virtually not much of a benefit at all. So from that point of view, it's useful. One more, the third type is a fulminant type, where there is a real organic damage to the liver, this pancreas, either due to surgery or due to some chemicals consumed. If there is a acute destruction of the pancreas, that produces fulminant diabetes, which is not a major concern in the routine clinical practice, but in a patient with, in a situation, surgical setup, ICU setup, trauma centers, this may have some significance, where earlier the patient was diabetic, but because the pancreas is damaged, the patient has developed diabetes. That's the issue. That's about the classic. Type 2 diabetes classification is, it also is of autoimmune origin. Major group of the type 2 diabetes whom we see would be autoimmune origin, which is also named as SAID, and it has almost the same features like a type 1. The patient tends to lose weight. Usually you get the history like initially the patient was overweight, diabetes started, and when the anti-diabetic treatment was started, patient has lost weight and there is a tendency to lose the weight continuously, and then the patient would be more bothered about the weight loss than the other. So usually in general, a type 2 diabetes, we say if the patient has lost weight, that's a good sign. But there could be a patient who tends to have a very significant weight loss and the consequences like progressive debility and so on, where it seems to be like a type 1 conversion. That is usually autoimmune. And in such patients again, Virechana can be somewhat useful, somewhat better useful. In a good number of patients, that progression can be arrested. I don't say that you can replace all the diabetic treatment. Anti-diabetic treatment may have to be continued, but this progressive or changes can be arrested in such conditions. Then there is another type of type 2 diabetes, which is also now named as a severe insulin deficient diabetes, type 2 diabetes, where the patient may have very high HbA1c more than 10 or so on. In these patients, though the patient may be primarily type 2 diabetes, you have to replace with the insulin. Insulin may be required. I don't say that any Ayurvedic treatment alone may be sufficient to manage that patient. Along with the insulin, of course, we may prescribe our drugs which may help in other way. The quality of life may improve as. Then in the severe insulin diabetes, again, it could be produced due to insulin resistance. This differentiation is practically clinically possible, difficult, because usually insulin resistance is more obese patients who have that typically tummy belly which is quite big, like pant size is quite big. In such patients, it's usually the insulin resistant diabetes, and in that condition, providing or increasing insulin dose may not help, but again Virechana can help in that requirement for increasing the dose of insulin. Otherwise what happens is progressively every time the insulin dose is increased, and I have a patient where 300 units of insulin per day was prescribed and the patient's blood sugar level was 400, and the patient was admitted with the hyperglycemia complications, ketoacidosis and so on. So that's how the issues are there. Rarely you may get such cases, but you may see such patients also. That's one record. What I have seen recently is a patient having more than 300 units per day of insulin, blood sugar more than 400, and patient having a ketoacidosis. That's rare cases, but still it may be possible. It's also seen. Then the other is mild obesity related patients who are relatively younger. Now this is another major category of patients whom we see, where the patients are obese and the patients are having a low category of diabetes mellitus, where HbA1c level is just around 8, 7 or less than 8 as such. In these conditions, they do not require insulin. These patients do not require insulin at all. They can be either managed with their Ayurvedic prescription, or at times you may require a oral and hypoglycemic drug. That again, the older hypoglycemic drug like metformin is always better than the newer generation drugs where the absorption from the GIT is affected. So that's the one issue. Then of course mild age related diabetes, that's also another category. Usually it occurs in the patients of above 50, a diagnosis of diabetes at the age of above 50 with the same sugar level, benchmark sugar level. That's also considered as the mild late onset diabetes condition, which may require very mild form of the treatment. Your intervention, medical intervention, either prescription of the medicine, Ayurvedic or modern, whatever it should be of a moderate degree, and you are not supposed to have a very rigid sugar level. Sugar level just marginally high, we can manage with that patient. That's issue. Now, to differentiate these different types of the diabetes, advanced tools are there, but many of them we are not using. Not practically, no regular practitioner will use, mainly for the research purpose, because I am supposed to talk about the topic. I just refer to that to say that I don't establish that I don't know. That cannot be possible. So establish that I too know about it. That's all the point. Otherwise, practically it's not of much importance. The current techniques, when sophisticated, would be autoantibody tests. It also is now possible to identify those autoimmune types of the diabetes, or C-peptide test is another test which also indicates about the insulin resistance. That's the other way. And gene testing, identification of the genes who are responsible for the diabetes also is possible. So rarely you may get a patient where these tests also are done and the patient may come with the report. I usually casually go through the report. There is not much of a use from the practical point of view. Maybe to a certain extent we may just modify the treatment. That's all. Next part, diabetes is as such is not a major issue. It's a silent killer. Rarely you may get a patient who has come for the diabetes as such. Of course, these days, because some of the patients, younger generation people would have a regular medical checkup and then they have issues concern about the report. Usually patients would not have a typical clinical presentation of diabetes. The patients would always come with the diabetic complication. This is true, and practically from the clinical point of view, this is a more important issue than really the management of the diabetes. So common diabetic complications. Again, diabetes is a disease which affects every organ of the body, and there could be any form of the complication. Any disease occurring in a diabetic patient would always have a step level poor prognosis than the normal usual. So a same even common cold in a diabetic patient would have a prognosis which is more difficult or one step lower. I use the word one step lower than the average healthy person. So that's true. But beyond that, the specific complications for the diabetes, the more common complications would be the nephropathy involving the kidney, most important, then the retinopathy, the eyes being involved, then the coronary heart diseases which are produced due to the diabetes, vascular pathologies, diabetic vascular complications where the patient may have ischemia and then the gangrene as such. Then neuropathy also is issue. Oral health, most of the times diabetic patients would have some foul smell lesions in the oral cavity and so on. So these are the very commonly identified specific complications of the diabetes. Now what I would be like to discussing would be identifying these patients and certain course way of dealing with from Ayurvedic point. From Ayurvedic point of view, these multiple organs involved due to the diabetes is well established. It's already mentioned in Charaka Samhita. Like Kalaprakarshat, Baliyamsa, Atava Anubandhanti. There will be Anubandha Vikara, which will be producing the involvement of every part of the body, resulting in Sarva Vighata Bhava Bhava Prativishesha. Every disease in a patient of Prameha would have a different prognosis than the other way. That's what's mentioned in Samhita. Of course, that's a very brief statement. Now we have more detailed description as well. Now, one by one, I will be dealing with a few of those common complications next. The most important is about the albuminuria or the renal pathology. Now, the first most sign, the initial most sign of involvement of kidney due to diabetes is albumin leakage in the kidney. Normally, albumin is not leaked in the kidney. Albumin, the protein, is one of the essential substance required in the circulation to maintain the osmolarity, so that the dynamics of the circulation are maintained, the most important function of the albumin, and it is synthesized in the body. And the normal mechanism is albumin normally is preserved. Every molecule of albumin reaching to the glomerular is sucked back at the glomerular level as well as next slide. I will not go much into the very detailed physiology. It is reabsorbed in the distal convoluted tubule, and in the normal situation there will be no albumin seen in the urine. Now albumin may get leaked to the urine due to many reasons. One is about the glomerular membrane. If the glomerular membrane is affected, that itself can result in the leakage of albumin. Or if the reabsorption at the proximal convoluted tubule or the distal convoluted tubule is affected, that also can affect the albumin metabolism, and there could be albuminuria. So the first and the foremost sign of albumin leakage due to diabetes would be considered as microalbuminuria, and we use the word microalbuminuria, where the amount of the albumin required is 30 to 300 milligram per day. To study the microalbuminuria, you will have to collect 24 hours of urine sample and then study as such. The routine conventional tests like assessment of the urine albumin would not be enough, because at the microalbuminuria level, that may not be enough to show that precipitate. In the usual albumin level, you sheet the urine segment of a urine in a test tube and see if there is this deposition. You say that albumin is present, and then give the first +1, +2 and so on. Microalbuminuria cannot be diagnosed with that single sample collected urine. It should be 24 hours of urine which has to be collected. Again, a tedious job, but at times it could be useful when there is a real suspicious case. As the incidence of diabetes and this albuminuria is quite high globally and as per the global data, particularly in type 2 diabetes, now all my focus will be about the type 2 diabetes, is about 20 to 40% in a patient who has a diabetes for about 10 years. So a diabetic patient of 10 years, there is almost a 40% chances that the patient may have already a initial sign of the renal involvement and the microalbuminuria may set in. Once the microalbuminuria is seen, that patient is at the risk of developing renal complication, and that's the benchmark. Like 300 is considered as a microalbuminuria level, that less than 300. If it is more than that, that's considered as albuminuria. Albuminuria, of course, you may identify a patient with that conventional routine test of urine, where it's already known that the patient has been already considered as a chronic renal disease. Microalbuminuria is not categorized as a renal disease, but a tendency for renal disease. Next, and again, statistically, once the perfusion, as per the data, by 30 years, almost all patients would result in a chronic renal disease, renal failure, end-stage renal failure. That ESKD is end-stage kidney disease, where the patient may require dialysis. This is about the average. And if any of your patient requires that or goes into a dialysis, by 30 years, you may feel, okay, our treatment also is quite good enough. If you can make the patient survive without dialysis beyond 30 years, then we may say that my treatment has helped. If the patient has to go for dialysis earlier to that, from the day of diagnosing of, now I am saying about diagnosing the microalbuminuria to end-stage renal failure, where the patient requires dialysis. From the universal standards, the standard protocol, now standard limits would be by about 15 or by 20 years, patient would have a definite diabetic nephropathy, where the blood biochemical tests like creatinine level also tends to be increased. For about 20 years from the onset of this microalbuminuria, creatinine level may be still normal. The biochemical test may be normal. It's only the albuminuria which is seen there. At that stage, virtually then the factors which hasten this is the usual set. Factors which hasten this, where the patient may go into a renal failure earlier than that, are mainly the patients who have a tobacco as a blood pressure, that maintenance of the circulatory pressure. If the blood pressure is higher, the patient would have a faster involvement of the kidney, and if the sugar level is very fluctuating. So from the contemporary point of view, the main three issues which are to be bothered is about the sugar level which has to be maintained. We say strict blood sugar level, regime, where the sugar level is very normal, regulation of the blood pressure, which is another important issue, and avoiding those habits like tobacco and alcohol is the other way, and regulation of the beta test. Other than that, there is no other definite preventive regime. From our clinical point of view, I have seen in many of such patients, prescription of Punarnamandura and Arogyavardhini helps in delaying these issues. I don't say that it can cure, but delaying the complication is possible. As I told, delay in the sense in terms of 20 years, 30 years and so on. Punarnamandura and Arogyavardhini has helped in a good number of patients. Along with these issues, the issues of maintenance of the blood sugar level, blood pressure level also is an issue as right. Next, now a patient of diabetes patients may develop into a chronic renal disease, where the patient may require this dialysis, can be produced mainly due to the hemodynamic factors, like where the blood pressure is constantly increased, or if the sugar level is not maintained properly, or the patient has the oxidative stress. That's important. Oxidative stress is mainly due to the diet, the current food habit. Persons who consume these packed food, stored food, that's one of the most common cause for the oxidative stress now. Most of those food sources which we get, including that bhaji, that podi, full vessel of podi was offered to me. Now, that also is one of the cause for the oxidative stress as such. And the incidence of chronic renal disease, where the patient has to go for the dialysis, is increasing rapidly, and at times that rate of patients going for the dialysis surpasses the rate of the incidence of the diabetes as such. And this is true in India. In Indian data, around 44% of the patients and of type 2 diabetes or 30% of the type 1 diabetes, they result in end-stage renal disease, or dialysis would be required. And that condition I would name as a Madhumeha. Now, again, I will not deal with that issues. Commonly we call every diabetic patient as Madhumeha, but it is not true. Textually, diabetes mellitus is a Kaphaja Prameha, it could be Ikshu Prameha. Madhumeha is the end-stage condition, and that end-stage is exactly the condition where the patient may go into a chronic renal disease and the dialysis would be required. Where Sushma said that Sarvaya Pramehastu Kalena Apratikarinah Madhumeha Pum Ayanti. tada asadhyaah bhavanti. With the Ayurvedic tools, it is asadhya. Dialysis may help the patient to survive for a bit longer period. So dialysis, I don't say that it is inevitable, but from there is a limitation to Ayurvedic treatment. Once the patient goes into the stage of chronic renal disease, there is a very significant limitation to Ayurvedic treatment approach. But earlier in the albuminuria stage, definitely yes, we can change the course as such. Next common issue is the other complication is retinopathy, involvement of the eyes. Now this also is made easily diagnosed by a fundoscopy. Fundoscopy is comparatively a simpler investigation where you just dilate the pupil and then look at the retina. The changes in the retina can be made out. One of the troublesome issue with this diabetic retinopathy is till it reaches a proliferative stage, proliferation different stage, there will be no clinical symptoms. Patient may have a normal vision. But once the proliferation stage is set in, then the patient may have minimal symptom, and the rate of progression from that point of view to result in a severe disease condition would be very short. So initially it will be lower gear, first gear, second gear, but reaching the fourth gear is short. That time taken is shorter, faster, and that's one of the troublesome. That's why now the standard protocol is every diabetic patient has to be subjected to fundoscopy regularly at an interval of 6 months or 1 year. That's the standard protocol now. Though it may not be rigidly followed, I think that would be one of the requirements in every patient of diabetes, with the idea of prevention of this retinopathy. As far as Ayurvedic protocol for prevention, I don't have any definite answer for that. Generally, I don't involve or interfere with that course, whatever the ophthalmologist would do. Now, once the patient reaches that proliferation stage, injection into the eye, steroid injection, is one of the remedies by which the further progression can be arrested. That irreversible changes can be arrested, and that would be definitely useful. So many of the patients, if they ask like whether I should go for that, I would definitely say yes, you have to go for that, because we do not have any means which is as definite as this intraocular injection. So I generally don't interfere in that, but this is one of the next. The other important issue is the cardiovascular complications from the diabetes. Diabetes affects the blood vessel system as well as the whole of the cardiovascular structures. The most common clinical presentation of these would be, one is insulin resistance. Simply a patient who tends to require more and more insulin, that itself could be the earliest sign of involvement of the cardiovascular. That's one. Or if the patient has a hypertension, patients who have significantly altered lipid profile, that and obesity also could be the initial more signs that this patient is going to develop a cardiovascular issue. Next way. The cardiovascular issues again are categorized into two categories: microvascular and macrovascular. The microvascular is more troublesome. Macrovascular easy to identify. Microvascular is quite difficult to that, and these microvascular complications mean where the capillaries are involved, the capillary circulation is affected, arterial circulation may remain normal. If you go for the Doppler study, the arterial circulation may remain normal, and such patients are more troublesome, and usually the microvascular complications would always accompany retinopathy, nephropathy and neuropathy. So patients would have more presentation of the neuropathy and the renal disease, and there the patient would also have a microvascular complication. There is no definite no definite tools no definite tools to identify the microvascular pathology. The only issue would be in a patient with the microvascular pathology, healing would be significantly. You will have a good number of patients of diabetes who say that any small wound results in more severe complications. That could be the most dependable clinical sign of making the microvascular pathology from the clinical point of view. Otherwise, of course, the evidences of involvement of the other organs easily, whereas macrovascular, thicker vessels being involved. Initial most simple test by which you can say that the patient is having a tendency to have the atherosclerotic involvement of the arteries is having that assessment of ankle brachial index. That's a measurement of the blood pressure at the ankle level and at the arm, and if the difference is a ratio of ankle brachial index is less than 0.5, then that's half of the pressure in the this arm is recorded in the ankle level. That's a very severe arterial pathology. On an average, the normal would be 1 to 1.5 is the normal average. When it is less than 1, it's always an issue of concern. So simplest tool is assessment of the blood pressure at the arm level and ankle level, which can give you a definite guideline. Of course, the other dependable tool is the Doppler study. Now these days Doppler is next Doppler is quite useful. Then again you have a lot of sophistication. Now the simplest Doppler would be the color Doppler, which gives you a better idea than the other types of spectral Doppler or power Doppler. Now these days this kind of newer techniques have come up, and the difference is only cost. A simple color Doppler average charge is around 800 to 900 in Udupi. In Bangalore or so on, they may be a bit more, it may be more. Whereas a power Doppler, you will be seeing only in a very sophisticated center, and it costs around 3,000. Ultimately, the information which you get is almost same, not much of a difference. Of course, one more newer technique which has come up is tissue Doppler imaging, a high resolution Doppler. Very few hospitals around our area are having that. KMC Manipal has recently got that tissue Doppler, and that tissue Doppler imaging would give you some better idea about the microcirculation. The peripheral capillary circulation also can be indirectly made out with the tissue Doppler, but cost of course is quite prohibitive. Anyway, that's about the issue. Simple assessment of there is a macrovascular, it should be macrovascular complication, can be otherwise by the simple Doppler flowmetry or infrared thermography, which is not so commonly used. Now, in a case of macrovascular pathology, our treatment protocol can produce a significant change, and what I would always prescribe along with the treatment for diabetes. Of course, when I say any of the prescriptions, it's along with the treatment for diabetes. Kaishara Gugulu Aragordini Manjastadi Kwata or Manjastadi Charabas. Manjastadi Charabasti produces a significant change. We could save many limbs. Many of the patients where amputation was advised, the amputation could be avoided with the Manjastadi Charabasti, which produces a very significant issue change, reversal of the macrovascular pathology. Next. Then another issue is the lipid profile being altered due to diabetes. Patients who now these days that lipid profile, cholesterol, and these issues have become a common issue. Many times patients are more educated than the doctor. They will know more about the cholesterol than the doctor. From the general point of view, in general, the pattern of a altered lipid profile due to diabetes. Now, lipid profile could be altered due to many other issues, diet and issues. The pattern of the lipid profile altered as a complication of diabetes, which has to be given more concern. Now, I stress upon this point because you will have plenty of patients coming with that altered lipid profile level, and they would be like, of course, the common prescription is statin. Now, almost more than 70% of people above age of 50, once they have visited a cardiologist, statin is essentially given. I say it's now more frequently used than the salt in the kitchen. Anyway, that's the other part. Again, not a criticism, but this is a fact which you have to know, and this also produces a clinical issue. But clinically, you will have some patients who have the question like whether I need a specific treatment for this altered lipid profile or not, or is it a complication of the diabetes. Now, the general trend in pattern of a diabetes induced lipid profile alteration would be the triglycerides level would be very high compared to the normal, and high density lipids are significantly lower. These high density lipids, which are considered as the good cholesterol, which is helpful in maintaining the circulation, that's a lower level. LDL would be almost in the normal level or moderately higher. VLDL, very low density lipid, which is more harmful, would be very significantly higher. Now, those patients who have very high triglyceride level, very high VLDL level, they are the patients who have a risk of developing the complications of lipid profile. Others may not be of that significant issue. So, in these patients, there is a need for a specific treatment for the lipid profile. Other alterations, other slight moderate variations, they need not have a specific treatment for the lipid profile alteration, and they can manage with the diet and exercise, or most of the times there is no need of treatment even. That's the other part. Statistically, it's now well known that the complications of cardiovascular complications do occur only when there is a significant increase in the VLDL and a significant reduction in the HDL level. Others are not to be concerned. And a good number of patients who are on statins unnecessarily, they would have a pattern other than. Now, for the sake of consideration, the normal level, the usual standard, a normal level in a healthy person, the total, I think this is well known, I don't have to stress upon this part, but to make the complete discussion, I would say that high density lipid would be having a high, if it is more than 240, that's something of abnormally high, and HDL level being less than 40 is a issue of concern. LDL level more than 190 is considered as very high, and triglyceride level more than 500 is very high. The requirement for a treatment would be only in those the third or fourth line patient in each category. The first to second or third line in specific cases do not require a specific treatment. That's all the part as it. And the issue is how lipid profile or lipid would be affecting the circulation would be very low density lipid. They have a bigger molecular size, a corresponding molecular size of a high this triglyceride, smaller molecule. Last one, high density lipid, relatively smaller molecule. The low density lipid, they have a bigger molecule, and because their molecule is bigger, they induce a inflammatory reaction in the vessels, and that results in endothelial dysfunction and complications of atherosclerosis and vascular blockade. Right, next, I think I will not go much into the theory. Now, from clinical guideline point of view, in India, there is a Lipid Association of India, which has given some guideline, which is now considered to be benchmark. ICMR also has accepted this benchmark as a standard, and that Lipid Association India guideline, I am not going to WHO guidelines. WHO guidelines are slightly different from this. So, from our current point of view, the guideline from the contemporary point of view is a triglyceride between 150 to 199. Initially you watch and assess whether the patient has a coronary vascular risk or not by other means. If not, there is no need of treatment there. In such conditions, lifestyle interventions, low fat diet, or so on. Only when the LDL level is increased, you have to go for the specific treatment. This is the guideline given by the ICM. But majority of the patients whom we see, they are overtreated. Many of those patients who come in that initial category, they will be overtreated. They will be having lot of drugs as such, and as I told you, it is the statins which are, and the statins are the major for this muscular pain, and this muscular pain due to rhabdomyolysis, that lysis of the skeletal muscles as a complication of the statin, would respond only to Kaishara Gugla and Mrityunjaya. So that is the best of the Amavata. And Ayurvedic practitioners, they can have better resources because the statin is very prevalent and we get more number of patients of that category. I say, that's why I say continue to use the statin. Okay, fine, we will have more patients, more money. That's big lighter sense. But there's also a part of the issue which is of concern, which is of a practical. As far as the ideal guideline target would be, a patient ideally, a patient should have a LDL target of less than 100 and the non-HDL target would be more than 130. This is the ideal target, and majority of the patients who are unnecessarily on treatment, they are within this target line, but still they are worth it. Now, from Ayurvedic treatment, if at all there is a specific question like altered lipid profile, can we manage with the Ayurvedic treatment? Majority of the patients do not require a treatment, medical treatment, but something which can produce a change is Virechana, Krama Prakara, Virechana, where you give the Snehana and then this Shodhana. Interestingly, when you give Snehana, when you consume more ghee, the lipid profile changes towards the norm. That's the interesting issue. High density lipids, that becomes reduced as high density lipids increases, low density lipids reduce when we give the Snehana during the Virechana. This also is now studied in many large number of patients, and even after the Virechana, for a significant time period, the lipid profile can remain altered, remain within the safe limits, provided the patient maintains that dietary regulation. If the patient overeats again within a few months, again it becomes back to the same as such. So I don't say Virechana is a totally curative treatment, but one of the effective tools by which we can modify the lipid profile level significant. Then the medical treatment otherwise could be Arogyavardhini Chandraprabha, which is I usually prescribe, and a good number of patients there would be satisfactory improvement. I don't say that it's a very dependable treatment, but there would be a satisfactory response. The most important troublesome issue is patients who have this altered lipid profile, they would have a question like heart attack. So to predict that, it's quite difficult. Of course, it's never possible, but there is a universal guide. The guideline is, if the patient is above 50, the risk would be high. Risk factors which produce these are the high that age group having this LDL level of more than 0.05 of normal range, that's more than 200, and patients who have a longer course of diabetes. Now the risk prediction reduces graph. I think that graph gives you the clear picture, and the total cholesterol, diastolic pressure and hypertension they have, and again with the hypertension, more than the intensity of the hypertension, it is the duration. Longer the time of hypertension, more the risk of this coronary accident. So with this you can to a certain extent predict that how many years, but not exactly. Then of course in the investigation point of view, CRP is one of the useful tools. CRP, if it is raised, that increases the risk of coronary risk as such. Then the other more sophisticated investigations now which are used not routinely in the routine clinical practice, we depend upon CRP more. The others are the investigations are interleukin test, and now one of the very popular tests which is gaining a lot of popularity is a coronary artery calcium, which has become quite popular now these days. So calcium level in the coronary artery is directly assessed, and by that the risk prediction is done. Right, next. So that's how the tools are done. Then another common complication is diabetic neuropathy. Diabetic neuropathy is the most common disease which we now see, and that again diabetic neuropathy could be categorized into mainly three categories: sensory, motor and autonomic. The most common symptom would be sensory, where the patient would have altered sensation. Initial most common symptom of that sensory neuropathy is a patient would feel as if he is wearing a chappal even though he is not using the chappal. And those patients who forgot the chappal in the clinic and then when they go back they leave the chappal along with your fees as such. Most of them they are diabetic neuropathies. If you can trace that which patient has left the chappal footwear at the clinic, you can make the diagnosis that patient has a diabetic sensory neuropathy. Then majority of the patients would have this. The motor neuropathy is the patient would have muscular weakness. Either it could be most common, it is the distal muscular weakness. The fingers, their muscle strength would be lesser. Patient would find difficulty in gripping the finer objects like pen and so on. Rarely it may be the proximal, where the thicker muscles, arm muscles could be affected, and hence the patient would have a difficulty in raising the arm or walking as such. Autonomic is less common from the clinical point of view. Autonomic is less common, but it is resulting in abnormalities of gastrointestinal tract. Majority of the patients would have flatulence, dyspepsia and so on, and the genitourinary symptom like that sexual impotency, sweat glands abnormality. These are the common symptoms of autonomic issue. That sensory involvement is considered as a pura rupa of Prameha in Sushma. That's interesting. Now we consider this as a complication of the diabetes. Sushma has considered this as a pura rupa. Now issues like why and how, that's not the point. Like we go next as such. The common tests which are done to confirm this neuropathy are the autonomic test, rarely done, only in very sophisticated hospital it is possible. Electromyography is mainly useful in motor neuropathy, EMG, which can differentiate that motor neuropathy due to diabetes or from other motor neuron disorder. Other motor neuron disorders, there will be an abnormality of the conduction. Time or activation of the muscles will be normal. In a diabetic neuropathy, the conduction will be delayed as well as the activation time of the muscles also will be increased. So that's the typical pattern as such. Then another test which has now becoming popular is monofilament testing for sensory neuropathy. It's a simple test with a wasp, cotton wasp. You go on touching the foot surface, trace out whether the patient can feel the touch or not. Now these days you have some sophisticated electronic instruments which also can produce a graph of these sensory impairment, and the areas of sensory impairment can be made out. With that identification of the sensory impairment area, a custom made footwear is usually designed in a sophisticated diabetic care hospital. One of the issues is the footwear which would be very specific for that patient is now prescribed, a custom made footwear, and the whole idea is identifying those zones of the foot which would have more pressure and lesser sensation. To protect that, you will have some padding on the footwear, and that's how it's done now. Then nerve conduction studies, of course, it's this electromyography only. There again you have different degrees of that. Sensory testing, quantitative sensory testing is more of a theoretical importance. For PG thesis we give that, otherwise not, where the testing is done with the numbers, given numbers as such, where you will have differentiation. As far as the clinical subtypes are concerned, from the clinical point of view, hyperglycemic neuropathy, where the patient would have these neuropathic symptoms in proportion to the blood sugar level. When the blood sugar level is higher, they would have more neuropathic symptoms. Once the sugar level becomes normal, they may have a better feeling. They themselves that I feel better. These patients do not require a specific treatment for the neuropathy. Only the sugar level has to be maintained. But this is not true in all patients. You may have patients who have the other way, where the patient may have a neuropathy constantly, and it could be either multiple neuropathies where the patient may have both sensory as well as motor, or patients will have that multiple polyneuropathy. Polyneuropathy is the patient would have some areas where the sensory is abnormal in some hand and then somewhere in the back, somewhere so on. Usually the patients will say that pigeon parapun symptom. That's what usually the terms used. Like in these patients, from our prescription point of view, I would be prescribing Ekangavira and Ashwagandha. Very severe cases, there will be a significant change with the neurohepathy or yapanabasti. Yapanabasti more useful in motor neuropathy, whereas sensory neuropathy, it is the neurohepathy which would be quite useful. Autonomic neuropathy, where the patient would have gastrointestinal tract symptoms like flatulence and so on, that would be always better response to Kamadukavati, which is Pitta Vyadhi, and patients who have cardiac involvement, tendency to have cardiac aberrations like pulse being higher or lower, rate of pulse being altered, heart sounds being slightly muffled, they can be managed with the Prabhakara. When the patient has a multifocal neuropathies, where there is a obvious atrophy of the muscle, or there is a demyelinating pathology where the reflexes also are abolished, the prognosis is extremely poor. No treatment can really help. All that treatment would be supportive treatment in terms of maintaining that position, and then all that artificial footwear, supports and so on, where from Ayurvedic management of view, there is a very little scope as. That's what I feel. Right, next slide. The last, of course, the next part is metabolic syndrome, which I referred to the issue in the beginning. Metabolic syndrome is considered as a pre-diabetic or something like a precursor to the diabetes, as well as one of the late complications of the diabetes. Multisystemic involvement. Multiple complications tend to occur. Majority of the patients who are diabetic now, they are of this category, where the patient would have a typical appearance of a metabolic disease, as I show in that diagram. It's apple and pear. Men would have that apple abdomen. Female would have a pear-like shape. This is what the usual simile given there. And the definition of metabolic syndrome, it varies from year to year. It's changed. The current criteria, current WHO criteria, which was presented in 2024, latest rather, is the waist circumference being 102 centimeters in men and the circumference being more than 88 centimeters in women. Waist circumference. Triglycerides more than 150. High density cholesterol level 40 milligram in men and 50 milligram in women. Blood pressure more than systolic blood pressure more than 130 and diastolic pressure more than 85 and fasting glucose more than 100. Any of these three features, if there is a condition, it is called as metabolic syndrome. This is the current diagnosis. And a patient of metabolic syndrome, if he is not diabetic at that moment, you can say that the patient has a high risk of diabetes. If the patient is already a known diabetic, you can say that the patient has a poor prognosis, outcome would be poor. In these patients, something which can produce some change from our adult point of view is Asanadi, Arogyavartin and Agni Chikitsa. Agni Chikitsa is what we give in SDM hospital, where we apply a lap over the body and restrict that food, and that itself is one of the protocols which is used in large number of Kafaja Vyadhis, and in these patients that produces somewhat significant outcome. I don't say cure. In these issues there is no question of cure. It's only about the modification of the disease course. This is possible with this treatment protocol. Next, the WHO next is very common issue which we see is diabetic foot and diabetic ulcers, gangrene. The issues. Diabetic foot again is defined in various fashions. Earlier, I am just quoting about the WHO definition. That WHO definition is it's only about the risk prediction, where there is a complication of diabetes which has produced due to multiple factors which can result in infection, ulceration or destruction of the deep tissues. So usually in the earlier classification it was about a diabetic ulcer, necrosis, osteomyelitis and gangrene. That's what we used to do. The current definition is of course the same, but it's slightly altered. And the clinical presentation of a diabetic foot, initially there would be not much of a sign. In the initial stage, first stage, it's about some areas of inflammation and pain, whereas the last stage it will be gangrene. And a good number of patients, they come to us at that last stage, gangrenous stage like condition. The diabetic ulcer at the end, that amputation is the ultimate choice in a diabetic gangrene once the tissue has dead. And prevalence in India is quite high. It's around 1.3% to about 24%, and it suggests about 6.2% of the diabetic patients who have ulcer. This is about the data from authentic source from India, from National Health Resource NHSRC data, published in 2021 to 2021, 4 years back. Now, of course, the latest data is this is the latest data, 21. Of course, current data may show some slight reduction in the number, and roughly around 15% of the diabetes, they tend to develop into gangrene within some decade or within 10 years of the diabetes. And amputation rates also are quite high in India. Around 85%, the total amputation done in the limbs, 85% are diabetic, 15% are due to non-diabetic reasons, either tumors or ulcers, these malignant tumors or trauma. That's the other reason. Now, the treatment, because of that prevalent incidence as such, Health Ministry has released a guideline for document the treatment of diabetic foot as such. So, this is available in web as such. The URL of the web is given. No, previous, just go to back. Previous, the URL of that is given. Those particularly student community, because it is around a 30-page document, I will not be able to refer to whole of that issue. But for every clinical practitioner should be aware of these issues, like how the guideline is given, because it is a ministry issued guideline. We should be aware of that. There is a need for that, which is it was released in 2021, though the date of publication is considered 2017, the first page of, next slide. I will be just showing you one or two of these salient issues of that guideline. Again, going to the detail is not the possible now. As per the guideline, again, I will be just quoting from guideline. What we really use in the clinical practice may be slightly different from that. The identification of these would be our clinical signs which you have to depend upon would be the appreciation of the wound. The depth of the wound has to be assessed. Cellulitis, when it is more than 2 centimeters, that is considered as severe, and the local signs of inflammation of induration or crepitus, sense of gas-like feeling, necrosis, these are all considered as the typical signs, standard signs of diagnosing as a diabetic foot, and where you have to you expect a serious diabetic foot complication. Now, I have just lifted up these points exactly verbatim, copied from the source. It's not my work, directly from the source. The diabetic complications which are suggested, and the patient who present with the acute onset or worsening rapidly, systemic signs like fever and chill, leukocytosis, or the patient who have evidence of foreign body or surgical implants, etc. That's considered as the possible high risk diabetic foot conditions, and the guideline is there is a need for appropriate antibiotic therapy. I do agree with that. The patients who tend to have a diabetic, rapid progressing diabetic foot, antibiotic would be necessary. Only the question is about selection of the anti-diabetic drug. Our anti-diabetic, this antibiotic policy, present day situation, they say third generation antibiotic policy as such, but practically it is the other way. The oldest antibiotic like gentamicin will be more effective than the other way. Anyway, that's the other part of it. Next, the risk prediction. Diabetic patients, diabetic foot patients, how to predict the risk of amputation. The guideline, again, I have copied this guideline as such. Again, it's about the same issue, suggests you about the inflammation. So I would recommend you to go through that article directly. But once we have identified that, the better would be, better remedial measures would be regular inspection and see like whether it is progressing rapid or not, and better could be the risk can be reduced by taking care of the foot. So education of the patient, maintaining the hygiene of the area, avoiding the pressure point that produces a significant change there, and the appropriate footwear. Now in case of the neuropathy, they have now there is a very rather popular issue, providing a specific footwear for the diabetics. That also could be issue. In such patients, something which can produce change in the duration, complications can be reduced to a certain extent. I don't say that it's a complete treatment, where the risk prediction can be reduced. That can be reduced would be by Trifurogugulu, Gandhakarasana, Manjistarikwata, given along with the management of the diabetes can help in significantly in such patients. I don't say that amputation can be completely avoided. Antibiotics cannot be completely avoided. You may require that, but this treatment protocol can help a bit in such patients. Next patient of diabetes, it is a union of all these complications, microvascular, macrovascular, or even the bone status. So patient would have a altered foot pattern, where often the people would be confusing this with the diabetic foot. It's not the diabetic foot, because the configuration of the foot is altered. Patient would feel the pain, difficulty, and change the gait. Gait is changed visibly. It's a very visible diagnosis. Look at the foot, you can make out that diagnosis. In that patient, there is no question of a complete curative treatment anywhere. All that would be a symptomatic relief. The pain symptom can be reduced by Gokshralikul Punarnavamandura given, by which the edema can be reduced, and all the other remedies like footwear, diabetic control, all of them would be essential. When I say this prescription, that doesn't mean that you can replace all of them. They are necessary, but with this we can modify. There is no need of any specific investigation. Even X-ray is not necessary to make out the Charcot foot. It is something which you can make out from the exterior. Next, the other rare complication is acanthosis. Rarely we see, particularly in black communities, it's lesser. More commonly seen in patients with the fair appearance. They tend to have that blackish deposition. A patient of diabetes having this blackish discoloration of the skin is considered to be a sign of insulin resistance. Popularly, it's considered to be a sign of insulin resistance, and that means the patient has to be given more insulin. At the same time, the incidence also is increased when the patient is given excess of insulin, both the ways. So there is no question of any specific remedy, but for the sake of completing, I have referred to that issue also as one of the complications. With this, I think I have taken a bit more time than where you do the Purva Karma, Pradhana Karma and Paschat Karma. And Paschat Karma is more important than the Pradhana Karma. that dietary restriction, samsarjana krama followed for the next 1 week is the most critical part in any shodhana. In virechana with the diabetics, it is the most crucial part. These days, one of the fashion which has become is virechana as a sample, particularly foreign patients and panchakarma treatment specialists. One divasa virechana kodudu, next day vamana kodudu, ಇನ್ನೊಂದು ದಿವಸ ಇನ್ನೊಂದು 5 ದಿವಸದಲ್ಲೆಲ್ಲ ಮುಗಿಸುವುದು. That's has become the fashion, but that kind of an approach can harm the patient. In a virechana, if you the samsarjana krama, that dietary restrictions for the next 1 week after the virechana is not followed, definitely it's going to harm the patient than the virechana. So virechana is a double-edged knife. If it is not used properly, it's and nitya virechana is not the issue. It's about the protocol of virechana where you give snehana. For snehana, you may give any of the ghritas. I usually prefer panchalikta gul ghruta, panchalikta gugul, but because it is quite bitter, some patients may not like that. In such patients, it may be the plain ghee also, plain ghruta also can be used. But that samsarjana krama after the virechana is very crucial.
Due to time constraints, Dr. Muralidhara Sharma will be leaving now. We thank you, sir, for taking the time out of your busy schedule and sharing your invaluable knowledge and rich clinical experience with us today.